Good morning, good afternoon, good evening to everyone. Thank you so much for joining us. Welcome to the International Society of Gynecologic Pathology Live Journal Club. Our theme today is ovarian serous neoplasms and fallopian tube. I'm Becca Wolsky. I'm speaking to you from the University of Colorado in Aurora, Colorado, with co-moderator Dr. Ian Hagemann here from WashU in St. Louis, from Washington University in St. Louis. And we also have Dr. Natalie Benet, of course, joining us, as well as our presenters who I'll introduce shortly. So, before we get to our programming today, I'll draw your attention to the upcoming ISGyP live events. On October 26th at noon Eastern time, Dr. Negar Taheri will be speaking on the ISGyP live podcast about factors affecting accuracy in frozen section. And of course, that'll be available for your listening thereafter. Also on October 26th, Dr. Jenny Bennett will be moderating the interesting case presentations by trainees or early career pathologists. So go ahead and register for all of those events if you haven't already and try to attend. A reminder that the ISGyP Journal Club is global, with the Western Hemisphere occurring the third Wednesday of every other month at noon Eastern time, and the Eastern Hemisphere occurring the third Thursday of the alternating months at 12 noon Melbourne time. Here's the schedule of the topics through the end of 2022, with the next being in November on gyne cytopathology. And it's unbelievable to me that we have just one more session in 2022, and you'll be seeing the 2023 schedule shortly. I just want to take a moment to welcome, along with Dr. Benet, to welcome Dr. Ian Hagemann. This is his first time truly co-moderating, and we're very happy to have him. As a reminder, we do offer detailed mentorship leading up to these presentations. So if you're interested in presenting at either Journal Club or interesting case presentation, please do reach out to one of us via the emails listed below. Now to the main event. Our three presenters today are Dr. Busem Binboga, a research fellow at Dana-Farber Cancer Institute. Dr. Kurt completed pathology residency in Turkey in 2020 and worked as a pathologist in a community hospital for almost 2 years before coming to the United States. Dr. Robson Cedro is a PGY3 at the Hospital of Clinics in Sao Paulo, currently broadcasting from Sao Paulo, Brazil. And finally, we have Dr. Lynelle Smith, a PGY5 at the University of Colorado. She's the Cytopathology Fellow and the Future Breast Gyne Path Fellow. And I want to thank all of the three volunteer presenters for all of the hard work you've put into this and getting to know your respective, often quite technical articles this month, and putting together these presentations for everyone. So the articles to be presented are listed here, and I'll ask each of the presenters to please read the title of your article at the start of your talk. The objective for this journal club are listed here on the screen. So it's to include engaging trainees and early pathologists, offering opportunities for presenting and moderating to members from all parts of the globe, providing mentorship, and engaging future leaders from around the world. That's all of you. And here's the outline and assignment that the three presenters received. So the schedule today, we'll hear from Dr. Binboga first, then Dr. Cedro, and finally, Dr. Smith. As a reminder, we're in a webinar, so please use the dedicated Q&A for questions to the presenters. And I believe you do have the option to upvote questions, and then use the chat. Please say hello to everyone. Let us know where you are. We love to see who's on the Journal Club Live. And now I'm going to stop sharing my screen, and Dr. Binboga, you can then share your screen. And I'll ask the other panelists to please ensure that you're muted, and the other panelists, you can feel free to turn off your cameras as well.
Hi, everyone. I want to thank the International Society of Gynecological Pathologists for reaching out all the way to Turkey and including me in this great effort. I was a pre-surgical pathologist when you reached out and built this bridge between us through my professors. Now I'm a research fellow at Dana-Farber Cancer Institute, and I'm grateful for this opportunity. I'll be presenting an article called HER2 protein overexpression and gene amplification in Tubo-Ovarian high-grade serous carcinomas by Dr. Ersoy and colleagues. It was published in International Journal of Gynecological Pathology in July 2022. HER2 is a transmembrane glycoprotein which induces cell proliferation and tumorigenesis. HER2 is an established therapeutic target in patients with breast or gastric cancer. Uterine serous carcinomas have highest rate of HER2 overexpression amplification among the endometrial carcinomas. Trastuzumab plus carboplatin paclitaxel combination in uterine serous carcinomas increased progression-free survival, approximately 4.6 months in HER2 overexpressed advanced or recurrent uterine serous carcinomas, and afatinib is also being investigated in clinical trials. For ovarian carcinomas, the percentage of HER2 overexpression amplification has varied among the most recent studies from 2% to 25% due to differences in patient population, cancer type, detection methods, and interpretation thresholds. HER2 amplification was reported as 0 to 7% in ovarian serous carcinomas. This study focuses on Tubo-Ovarian high-grade serous carcinoma due to advanced stage at initial diagnosis, death led by progressive recurrent disease. So alternative treatment options are needed. 100 Tubo-Ovarian high-grade serous carcinoma patients who underwent cytoreductive surgery were included in this study. 13 of the patients received neoadjuvant therapy. All cases were reviewed retrospectively. Best one block was selected for IC and FISH. Follow-up data in terms of recurrence and overall survival were available for 98 and 57 patients, respectively. Pathway anti-HER2 monoclonal antibody was used for IHC, and membranous immunoreactivity for HER2 protein expression was scored according to the 2018 ASCO-CAP HER2 testing guideline in breast cancer, and divided into 3 groups: 0-1+, 2+, and 3+. A dual-probe FISH assay from Decoagulin was used for FISH analysis. It was applied for all the 2+ and 3+ cases, as well as 5 of the 0-1+ cases. Tumors with average HER2 copy number greater than or equal to 4 signals per cell and HER2 sub-17 ratio greater than or equal to 2, or HER2 copy number greater than or equal to 6 signals per cell, regardless of HER2 sub-17 ratio, were classified as HER2 amplified. Authors also described heterogeneity as staining in contagious extent with a different score than the original score in at least 5% of the tumor cells. An example is 2+ cases demonstrating at least 5% tumor cells with 0-1+ score or 3+ score in contagious extent. 4 categories are determined in HER2 testing in breast cancer. It is based on membrane staining intensity and 10% cutoff. Each evaluation is based on 5 different groups concerning the ratio and HER2 signals per cell. Positivity is defined as a combination of these each groups and IHC results. This is a great representation of HER2 protein expression by IHC from the article. We see moderate staining in B and intense staining, which is 3+ in C. Authors also indicated basolateral staining in some cases, which is also a feature that is seen in HER2 expression in uterine serous carcinomas. We see an example of a 2+ case that had above 5% 0-1+ area defined as heterogeneity. Results. Mean age was 65.2 years. Pico stages were 10% stage 1, 7% stage 2, 61% stage 3, and 22% stage 4. The median follow-up was 2.7 years, and IHC scores were 0-1+ in 81 cases, 2+ in 18 cases, and 3+ in 1 case. Heterogeneity in HER2 protein expression was observed in 17% of cases, which were mostly 2+ cases. The only 3+ case and one of 2+ cases were confirmed to be HER2 amplified. These cases were diagnosed at stage PT3B and PT3C, and they did not receive neoadjuvant chemotherapy. All patients who received neoadjuvant therapy were scored as 0-1+, and one neoadjuvant case demonstrated subclone. Since 30% cutoff was used in clinical trials for uterine serous carcinoma and recently proposed as one of the cutoff levels to evaluate HER2 studies in uterine serous carcinoma, all the cases were scored using this cutoff to see how it would affect the overall results of this study and selection of the cases for FISH. Overall, decreased the number of 2+ cases from 16 to 10 cases, but it did not change the original scores of the 2 HER2 amplified cases, which remained as 2 and 3+. The only 3+ case by IHC with the corresponding FISH image. One of the neoadjuvant cases demonstrated this subclone comprised below 10% of the entire tumor. Other neoadjuvant cases were 0-1+. When it comes to survival results, recurrence and progression rate was 62%. 2 HER2 overexpressed amplified patients were in remission with no recurrence on their 3- and 6-year follow-up, respectively. Subclonal patient was staged as YPT3C and had recurrence followed by brain metastasis, but it was not sampled, so we don't know its HER2 status. Median overall survival had not been reached. There are several studies that use tissue microarrays. In first study, investigators found 4.4% HER2 gene amplification in ovarian carcinoma and 3% HER2 gene amplification in ovarian papillary serous carcinoma. Other study found HER2 gene amplification in 4.7% of high-grade ovarian serous carcinomas with good concordance between IC and FISH using ASCO-CAP 2013 guidelines. Other studies show discordance between IHC and H in terms of HER2 overexpression amplification in serous ovarian carcinomas, and some use other criteria for evaluation of HER2 status. This is the first study that focuses on Tubo-Ovarian high-grade serous carcinomas using whole section slides. 2% of Tubo-Ovarian high-grade serous carcinomas were found to have HER2 overexpression and amplification. Strong correlation between HER2 IHC and HER2 FISH using 2018 ASCO-CAP HER2 testing guideline for breast cancer was found, although they did not apply FISH to all cases, to emphasize on this. Data in terms of prognosis shows controversial results. Whether HER2 is associated with chemoresistance or chemosensitivity is still an area worth diving deep. There are also clinical reflections. A phase 2 trial for trastuzumab as a single agent monoclonal antibody in persistent or recurrent ovarian and peritoneal carcinomas found response rate of 7.3%. And activating HER2 alterations may benefit from alternative HER2 targeted therapies such as tyrosine kinase inhibitors. I believe heterogeneity and subclone terms and descriptions made by others are promising concepts in terms of overall HER2 implementations. So I would like to hear more about heterogeneity and subclone in the discussion part. Study had relatively small sample size to emphasize the actual percentage in the population and low number of available follow-up cases, and the number of patients alive at the time of the data analysis may have limited survival outcomes. Overall, this study targets a specific patient group that has been diagnosed in advanced stages and has a high recurrence rate. A sustainable method for our daily practice, they suggested 2018 ASCO-CAP HER2 guideline for breast cancer can easily be adapted for these patients. Even though 2% seems rare, HER2-targeted therapy is worth consideration in selected patients, and the patient population who may benefit from treatment can be expanded in future studies if molecular studies are also involved. Thank you.
That was fantastic. Thank you. I don't see any questions from the audience right now, so I'll ask you if you had a biggest takeaway, something you found most interesting from this article.
I believe in the future, patient-focused, patient-tailored therapies will rise. So even though they found 2% point estimate, it may still be a target for this patient population. So this is my takeaway.
So overall, moving towards a precision medicine model where we tailor individual treatments. Yeah. Oh, we have a question that's just appeared. Let's see. Because high-grade serous carcinoma has such high intratumoral genetic heterogeneity between anatomic sites, did the author suggest that more than one blocker site should be tested? Do you want to take the first shot at that?
It is not indicated in the article. They say that one demonstrative block was selected without necrosis and other factors, but heterogeneity is definitely an issue.
And Dr. Hagemann, did you want to add something?
Oh, I was just clicking off that it had been answered in the manager, but I would add, I think it's salient that this study did use whole sections rather than tissue microarrays. So that's the strength of their methodology.
Yes, I think what the question from Dr. Karnezis was getting at that, and it's important to not overlook the fact that, as you said, you know, this is one study that does use whole slide sections. I think that can often be overlooked when reading a paper. You know, microarray versus whole slide section sort of gets swept into the minor details, but we know in practice often there's heterogeneity in many immunohistochemical stains, right? And so I always do, I understand it's more resources, it costs more to stain whole slide sections most likely, but I think in a case like this, it's really useful. So that's one thing the article had going for it. And the point of tumor heterogeneity is important, not just within one tumor, but across multiple sites throughout the patient's body, perhaps. Did you want to say anything else, Busem, about that? I mean, Dr. Binboga, excuse me.
No, I think the whole section slides part of the study is definitely a strength comparing to tissue microarrays.
Yeah.
Yep.
Yeah, we know, I mean, we know from, I can't remember if they mentioned it in this article, but we know from the uterine serous carcinoma experience that the primary tumor and metastasis don't always, that are not always concordant in terms of their results. So heterogeneity within tumors and across the patient's multiple tumors is something to think about in the future for sure. Okay, with no other questions, I think we can, unless anyone else wants to add anything about this article right now, we might have more time at the end as well. We can move on to our next presenter. So Dr. Cedro, do you want to share your screen?
You can see my slides now.
Yes.
So my name is Robson Cedro Filho. Thank you for this opportunity. I am a pediatry at Hospital das Clínicas da Universidade de São Paulo in São Paulo, Brazil. Today I will talk to you about this article, Cytoplasmic Pattern P53 Immunoexpression in Pelvic and Endometrial Carcinomas with TP53 mutation involving nuclear localization domain, an uncommon but potential diagnostic pitfall with clinical implications, written by Dr. Rabban et al. And published in the American Journal of Surgical Pathology. Firstly, we are talking about the p53 protein. That's the product of the TP53 gene. And it's very essential to us to have some knowledge of the structure of this protein. Its protein have 393 amino acid residues, and they are divided in some domains. The first one is the transactivation domain, and is very important to the apoptosis of the cells. And this proline-rich domain is also involved in this function. We have almost in the middle the DNA binding domain. That's very important, and usually most of the TP53 mutations occurs in that domain. The NLS, that is the nuclear localization signal, okay, that can be also known as nuclear localization domain, is responsible for signaling the import of the p53 into the nucleus. The tetramerization domain, it's responsible for the quaternary structure of this protein because it's composed of 3 p53 proteins. The NES, that is the nuclear exclusion sequence, it's inside the tetramerization domain, and is responsible for the export of the p53 to the cytoplasm. And the last one is the basic domain, that it has a function of regulating this protein. And why I was talking about that, because this has some kind of relation with the p53 IHC staining. We know that are 4 patterns, 3 of them are abnormal patterns. The first one, just for exemplifying, is the wild type pattern, where we have focal nuclei staining, while the overexpression pattern, we have a diffuse and strong nuclear staining. The null pattern, there is any degree of nuclear staining, and the cytoplasmic pattern usually has a strong and diffuse cytoplasmic staining, and is already know that there is some kind of correlation between the TP53 nuclear localization domain mutations and this kind of cytoplasmic staining. So the authors hypothesized that mutations adjacent to TP53 nuclear localization domain could also be involved in p53 protein localization. And those domains, as we saw in the first figure, are the tetramerization domain and the nuclear exclusion sequence. They also thought that the cytoplasmic pattern in ovarian and endometrial carcinomas are prone to misinterpretation as wild type or equivocal. This study aims to describe p53 IHC patterns and clinical pathologic characteristics of pelvic and endometrial carcinomas with the p53 mutations in nuclear localization domain, tetramerization domain, and nuclear exclusion sequence by NGS, and also to examine prognostic significance of these TP53 mutations by performing survival analysis on the ovarian high-grade serous carcinoma cohort of the CGA project. So about the methods, the authors, they made a retrospective query of their NGS database, and they searched for endometrial and pelvic cancers harboring these mutations that we were saying in LD, TD, and NES. Then they reviewed p53 IHC staining from those cases, and lastly, they extracted data of the cases of the CGA project harboring TP53 mutations, all, and compared the survival outcomes of these groups. For interpreting p53 IHC staining, the authors relied initially on the ISGyP recommendations. Initially, if these cancer cells had a diffuse and strong nuclear staining, the overexpression pattern was recognized. if there was any degree of nuclear staining, the null pattern was diagnosed. When cases didn't met the before mentioned criteria, the authors looked at the cytoplasm, looking for some kind of cytoplasmic staining. When the cytoplasmic staining was present in half or more of the tumor cells, the cytoplasmic pattern was confirmed. However, if the cancer cells didn't have any kind of degree of cytoplasmic staining and nuclear staining, so the wild type was diagnosed. And in equivocal cases, they suggest for us to use P16 staining and TP53 molecular testing. However, all the cases here in this series had already done the molecular testing for the TP53 mutations. So the authors identified 31 patients with pelvic or endometrial carcinomas that harbored NLG, TG, or NES mutations. The most common was NLG, followed by NES and TG. The median age of the patients was 65 years. The vast majority of those cases were high-grade serous carcinoma or carcinosarcoma. The other cases were the differentiated endometrial carcinoma, clear cell carcinoma in the endometrium, and endometrioid carcinoma in the ovary. It appears that the location of the mutations in TP53 affects the pattern of P53 staining. The NLD mutations resulted in staining predominantly localized to the cytoplasm, while TG or NES mutations resulted in nuclear expression overlapping with some degree of cytoplasmic accumulation of this protein. The cytoplasmic staining was seen in 27 tumors. However, 5 of them were classified as having the overexpression pattern due to diffuse and strong nuclear staining, while 22 were classified as having the cytoplasmic pattern. And none of the P53 null pattern tumors exhibited cytoplasmic staining. Here, in this figure extracted from the article, we can see 6 cases. All of them were classified as having a cytoplasmic pattern, and we can see that not only the cytoplasmic pattern is present, but some degree of nuclear staining also exists in the same tumor cell. The first 2 cases, we have this impression of more nuclear staining, while the last 2 cases, we have less nuclear staining. However, the threshold of 80% of the nuclei of the tumor cells with strong staining wasn't present. So the cytoplasmic pattern was diagnosed for all these cases. Here we have an example again from the same article where those 2 cases have the cytoplasmic pattern. However, it could be easily misinterpreted as wild type pattern or equivocal pattern. However, by molecular testing and using the cutoff of half or more of the cells exhibiting some kind of cytoplasmic staining, those 2 cases have the cytoplasmic staining recognized. On the overall, cytoplasmic staining was present in 71% of the cases, followed by the overexpression one with 19% and the null pattern with 10%. Here on the right, we have another figure from the article where the expression pattern was present in this case, but we can also see that the cytoplasmic pattern, not exactly pattern, but cytoplasmic staining is also present. And this makes a contrapoint with the previous figure, showing us that there is a spectrum of staining, not only of the cytoplasm, but also of the nuclei. The outcomes from the CJ cohort, the authors found for 171 cases. They are all, as we said, high-grade serous carcinomas, and 9% of them had TP53 NLD, TD, or NES mutations. When compared, as we can see here on the figure on the right, both survival curves are very similar, and overall, it was the statistically different, the surviving, the survival of those two groups. This is a proof that mutations in NLD-TD and NES, compared with other more common mutations in the DNA binding domain, have a prognosis that is so bad as the more common. In the discussion, the authors said to us that the P53 cytoplasmic pattern is a heterogeneous spectrum of cytoplasmic and nuclear staining of varying stain intensity and distribution. NLD, TD, and NES mutations may produce P53 nuclear overexpression pattern with a component of cytoplasmic staining, true cytoplasmic pattern, or null pattern. Despite the majority of mutations being loss of function, most tumors retain protein expression, suggesting that these mutations were not subject to nonsense-mediated decay of the TP53 messenger RNA, which means being degraded on cytoplasm. There are some limitations and strengths of the study. The first limitation is having a biased sample and selection, because these cases, they were retrospectively queried, and the molecular testing was made by assistant oncologists and pathologist preferences, so we don't know the criteria for all these cases. There is a short follow-up time, and we really don't know what will be the survival outcome of those patients in 5 years, we could say. There is a lack of control group to compare the cytoplasmic staining in these cases with other types of carcinomas. The practical value of P16IHC in equivocal cytoplasmic staining is open to future studies, and the strengths are being the largest series to date on cytoplasmic pattern of P53IHC. There is correlation between NGS and IHC, and it helps to identify the heterogeneity of P53 IHC patterns, focusing in the cytoplasmic pattern. There are some applications of these results. This study helps to identify the cytoplasmic pattern of P53 IHC as abnormal. It also raises awareness about the P53 IHC heterogeneity, so it helps us to avoid misinterpretation of future cases, and it, in some sense, ratifies the current ISGyP recommendations for P53 IHC interpretation. That's all. Thank you.
That was excellent. Thank you so much. Right now, no questions in the Q&A. We have about 2 minutes until we should get started on the final presentation. So Dr. Cedro, was there a part of this paper that was perhaps most interesting to you, or the biggest takeaway point for you?
For me, the thing is, I've never seen before a case with P53 cytoplasmic pattern. Only one, I think, that was really a photo of a case from a private laboratory. And I think it really helped me identify this pattern, because it's not uncommon for us to see some IHC staining that is some kind of weird, and we think, oh, this is nothing, this is related to other problems with our machine, or with the formaldehyde we use. But I think it's really important to identify this new pattern, because it's very common for us to use P53 IHC staining in our daily routine.
Yeah, so it's really nice to see the image with the range of cytoplasmic staining, right? Because we encounter it, but not often. And For me, at least, that was a great part of it. I think any other panelists have any questions or comments about this? Deeper? Okay.
Well done.
Yeah, that was great. All right, so we will move on to our final presenter. This is Dr. Smith.
All right. I just wanted to say thank you to ISGyP to allowing me to have this opportunity to talk to you all today. So I will be speaking to you today about this article, Deep Learning-Based Histotype Diagnosis of Ovarian Carcinoma Whole Slide Pathology Images by Farahani et al. So just a little bit of background. Ovarian carcinoma has the highest mortality of all female reproductive cancers. And as time has gone on, treatment has become more and more tailored to the histotype of those cancers. And unfortunately, sometimes histotyping can be quite challenging. And in this paper, they cite a low inter-observer agreement between general pathologists of 0.54 to 0.67 by Cohen's kappa. Overall, in general practice, there is a lack of gynecologic pathology expertise, and there is an increasing demand for more and more complex specimens to be examined by pathologists. So the hypothesis of the study was that machine learning-based image classification models may be able to recognize the 5 most common ovarian carcinoma histotypes sufficiently well that it could aid the pathologist in diagnosis. Their aim was to develop a generalizable model for automatic ovarian carcinoma classification using deep learning-based algorithms, regardless of the imaging modality, the tissue processing techniques, and the staining procedures, in order to enhance the pathologist's efficiency and diagnostic accuracy. Listed here are the 5 most common ovarian carcinoma histotypes, with high-grade serous carcinoma, clear cell ovarian carcinoma, endometrioid carcinoma, low-grade serous carcinoma, and mucinous carcinoma. The authors of this study utilized 2 sets of data in order to train their machine learning models, the characteristics of which are broken down here in Table 1. You can see that each data set had cases from each of the 5 most common histotypes. The internal data set is the training data set, and they had 948 whole slide images, or WSI, taken from 485 patients. These slides were scanned at 40x scanning objective on an IntelliSight ultra-fast scanner, and the reference diagnosis is the gold standard diagnosis. And for the internal data set, they used an expert pathology review of the H&E slide along with any IHC and any other assays that were available to them. The external data set is the testing set, and this consisted of 60 whole slide images from 60 patients. Again, they were scanned at a 40x scanning objective on an Aperio CSO scanner. And for the reference diagnosis, or gold standard diagnosis, the authors of the article reviewed the H&E slides along with an 8-panel marker of IHCs called the COS-PV3 panel. Figure 1 here shows the training and testing pipeline. And the first step in the process is to annotate the slides. So with the internal data set, around 400 whole slide images were annotated by a board-certified pathologist who went into the digital slides and circled the areas of tumor. They then took those slides and trained a computer to do the same task of circling the tumor versus non-tumor. Those are the so-called pseudo-annotations. Once they had completed that, the computer extracted what's called testing patches, and the patches are just predefined areas of pixels that the computer can assess individually. They then repeated the process on the external testing set, except they didn't do pseudo annotations on the external testing set. They had just the board certified pathologist circle the areas of tumor, and then the patches were extracted in the same manner. The next step is the color normalization step. In this step, what they did was they took 3 different techniques to normalize the color of the testing patches that had been previously described in the literature in order to make sure that all patches were assessed at the same color intensity. And then finally, the last portion of this model was to take these patches and test them with a variety of different deep learning testing models. They first trained it on the internal data set and then tested it on the external data set to come up with a slide level histotype prediction. This next slide, we're going to be going over the different types of models that they had used. So listed on the left-hand side are the first 2 types of models that they had used. These are convolutional neural network models. One STL takes the patches at 20x and assesses them and then classifies them into one of the 5 histotypes. The slide level diagnosis is then calculated by a majority vote of the patches. Whereas 2 STL is essentially the same. The only difference really is that they assess each patch at 10x and then at 20x, and then a slide level diagnosis is calculated. The last 2 models listed here are multiple instance learning models. DeepMill assesses the slide as an entire entity rather than as individual patches, and then it comes up with a slide level diagnosis directly, so it predicts what the slide is based entirely on the whole slide. VarMill is similar. The only difference is that it adds in a calculation in order to account for overall tissue heterogeneity. Here in Table 2, they show the mean slide level diagnostic concordance against the gold standard, and you can see here that 1 STL had the highest mean slide level diagnostic concordance with more than 80%. Table 3 then focuses on the details of the 1 STL model, and importantly highlighted here is the Cohen's kappa. And you can see that in the training set and in the testing set, the agreement between the AI and the reference diagnosis is quite a bit higher than what was cited for a general pathologist. And to remind you, that was 0.54 to 0.67 for the general pathologist. So it does quite a bit better. The authors of this model realized that in clinical practice, many cases have multiple slides of tumor, and they wanted to know whether or not their deep learning model would perform better when they were given multiple slides for a given patient. They tested this with their internal data set, and they were able to show that the patient-level diagnostic concordance was much higher than that for a slide-level diagnostic concordance, with more than 5% better in the overall patient concordance. They did find that there were 8 discrepant cases in the 1 STL model. Overall, the models had a difficult time with endometrioid carcinomas, and you can see here in the testing set that it was able to accurately predict that it was endometrioid in about 50% of the cases. And you can see here that in this confusion matrix of the testing set, that half of all of the endometrioid carcinomas were misclassified, either as high-grade serous or as mucinous carcinoma. Table 5 and Figure 3 show all of the discordant cases, and overall, what they did was they took the discordant cases and had 2 of the authors blindly review these cases independently and come up with their own diagnosis. Overall, the reasons for discordance amongst these cases tended to be due to tissue heterogeneity and overlapping morphologies. Interestingly, in 4 of the 8 discordant cases listed here with the stars and shown down below with the stars, the independent review by the pathologist actually agreed with the AI and not with the reference diagnosis. There was a single case where the they thought that AI had come up with the incorrect diagnosis entirely, and that is outlined in red here. And you can see that the AI thought this was a high-grade serous carcinoma. The reference diagnosis was endometrioid, and the independent review agreed that it would be an endometrioid, and you can see that image down here. This last figure, it shows how the AI interprets each patch. So you can see this top figure here on the left-hand side is the whole slide image, and over here is that image with the testing patch predictions overlying the top of it. Overall, this slide has an orange hue to it, and that would correlate to the endometrioid carcinoma. They do highlight a few patches here and there to discuss further, and this first patch with blue, the AI had incorrectly predicted this to be a mucinous carcinoma, and given this patch, you can see that you have a somewhat pseudostratified columnar epithelium with what appears to be mucin in the cytoplasm, so it is understandable why the AI might have thought this would be a mucinous carcinoma. This green patch here, it correlates to this image here, and you can see that you have single individual cells trickling through the stroma, and this was incorrectly predicted to be a high-grade serous. And then finally, they highlight a patch that was correctly predicted to be endometrioid, and it does look to resemble what we think of as a classic endometrioid carcinoma. So the authors of this paper were able to identify a deep learning model, 1STL, that performed superiorly to all the others. The highest slide level it had the highest slide level diagnostic concordance. They did find that color normalization was key to making this model overall generalizable, and they predict that patient-level diagnosis would be better with multiple slides per patient and have a higher level of concordance. They do think that diagnosis on H&E alone is not always possible due to morphologic discrepancies, and interestingly, the review of discrepant cases did yield expert agreement with half of all of the cases with the AI. The algorithm itself provides opportunities to improve practice for the general pathologist to diagnose difficult cases, and they cite that their AI can formulate a favored diagnosis very quickly with high diagnostic concordance. They say that it can happen within seconds. They don't believe that this can replace a surgical pathologist, especially because there are cases that have unusual features, there's morphologic overlap, and they may be misdiagnosed by the AI. They do, however, think that this could be used as a diagnostic adjunct to a fully digital surgical pathology service. In terms of my suggested future directions for these authors, I do think that additional testing against a variety of testing sets from many different institutions could help to further affirm that the model is generalizable across all tissue processing techniques. I also would like to see them broaden the machine learning algorithm in order to include other ovarian cancer types, not just epithelial types, and then benign things as well. And then, due to the possible misclassification based on H&E alone, I would like them to determine whether or not the algorithm could provide some sort of confidence score in order to flag difficult cases for further review for anybody who would be using this AI. And I also wondered if there would be a way to integrate studies such as IHC into the overall assessment by the AI of a case to help increase the predictive value of the AI. And then finally, the authors do suggest that this diagnostic tool could be used in a fully digitized practice. However, my mentor and I were discussing this article, and one thing we thought of was whether or not this algorithm could be used to provide some sort of diagnostic assistance to practices that are resource limited. Perhaps if they could send off slides to be scanned somewhere, and then those scanned images could be uploaded into the algorithm and then spit out a prediction for them to help assist them in creating their diagnoses. So with that, I would like to say thank you. I would like to give a special thanks to Dr. Michael Yang and Dr. Toby Cornish, who are two of the faculty here at the University of Colorado, who have some expertise in this field of AI and bioinformatics. I do not have any expertise in this field, and I would have been totally lost without them, so I really appreciate their help in dissecting some of that technical language for me. And that is all I have, so I will take any questions.
I applaud you. I think, Dr. Smith, you meant to say you did not have expertise because you do have some now. I have questions now. So what do you think, Dr. Smith? What was your biggest takeaway?
So I do think that this is kind of a hopeful study in that they were able to, they had kind of built on some other studies that I didn't really go into, where they had, I think the biggest thing was that they were trying to make this generalizable, right? And so them trying to integrate a few different color normalization techniques can really help with that. And so I think that, you know, in the future, this might be a widely applicable thing. I do see like there's a question about cannot replace a general surgical pathologist, and yeah, so if this technology continues to evolve and we can kind of reduce any variability in the tissues, it might become more widely used. So I think it was a very good proof of concept paper in that aspect.
Absolutely. This was, to be honest, new information for me as well. I would venture to guess many people on this call. I don't work in a fully or not really even partially digitized system myself. Dr. Hagemann, do you do any digital pathology, just for starters?
Oh yeah, we use it in very circumscribed situations. We have a few algorithms that we use, but they require a lot of guidance from the pathologist, and they have error traps, meaning that there's always that 10% of cases that don't play well with the AI.
And I'm curious, is there any sort of way that this is flagged for you all as you practice real time?
Flagged, that the errors are flagged. I mean, mostly.
That the potential errors are flagged, or is that not possible?
Yeah, I mean, whoever's supervising the AI would notice that it's not giving the expected results. So it does require someone with expertise currently. You know, there's interest in possibly generalizing these techniques to low resource settings. You don't have a pathologist, but we have this algorithm. So I think that one of the risks is that if you don't have the supervising human operator, errors may slip through. The other example that comes to mind here would be metastatic tumors that this algorithm would probably classify as whatever it thought was the most likely category.
Yeah, it would definitely need to broaden the differential substantially, right? To essentially to all possibilities to be accurate.
Yeah, this training set included primary ovarian cancers only, so that's the only entities it knows about.
Right, and I
wrong.
specifically carcinoma specifically, right, Dr. Smith?
Yeah, that's correct. Yeah, so that was one of the things that I thought was sort of a major flaw, and I do hope that these authors pick this study up and kind of broaden it to other tissue diagnoses, not just carcinoma, but you know, other mesenchymal tumors or metastases or benign entities, which was not assessed. Yeah.
And of course, they have to start somewhere. I mean, I think
exactly.
It is a tremendous study, and it gives us a lot to think about. You know, when I think about ancillary tests like immunohistochemistry and now molecular testing, I have those tests readily accessible to me at this institution. I'm aware that many people in practice, many people who are in our audience today, I would venture to guess, don't use immunohistochemistry because they don't need it or it's not available, right? And so this, you know, when I first think about it, it seems like another technology that will cause further disparities, be available to some practitioners and not others. But my hope would be, as Dr. Smith mentioned, she and I were discussing that somehow it could be broadened and perhaps help in a place where one pathologist is handling types. I thought that you did an excellent job in a typical paper. And do you have any other questions? No, right, Dr. Hagemann?
No, no other questions.
All right. Well, I want to thank you three presenters so much for doing such a fantastic job, being very diligent and volunteering your time. And if anyone wants to do this in the future out there, please email Dr. Benet or Dr. Talia for the journal clubs at least. So with that, I would encourage the audience to please fill out the survey. We do carefully pay attention to and try to adjust according to those results of your surveys. We want to hear from you. So I think we can conclude, and we'll just, I apologize if people are having trouble hearing me today. But yeah, we can conclude and we'll just keep the meeting on and allow people to fill out those surveys. So please do that. Thank you so much.